So in this image you can see here that there is one catheter which is inserted into the bladder and dye has been injected. So obviously this is cystogram, and what kind of cystogram? This is retrograde cystogram. Hi guys, this is Dr. Pritesh Singh, Surgery Faculty at PrepLadder and author of Surgery Sense, AIMS Sense, NEET Sense, Quick Review of Surgery and INI-CET Sense. These are my best-selling titles. So let's start the discussion of INI-CET May 2022 surgery questions. Question number 1. A 37 years old unmarried female nulliparous having regular sexual intercourse on OCPs since last 3 years gives the history that her mother had carcinoma breast at 50 years of age. So first important point, that the patient's mother had carcinoma breast at 50 years of age and sister had ovarian cancer at 40 years of age. So what you can see here, that two family members are having breast and ovarian cancer. Whenever two family members are having breast and ovarian cancer, this is an indication for genetic testing or genetic counseling. Now see the question, what will you advise as next step? So female patient is having positive family history. Her mother was having CA breast at 50, sister was having ovarian cancer at age 40. See the option, stop taking OCPs. OCPs are not a significant risk factor. Clear? So here, this is not the appropriate option, that she will stop taking OCPs. Nulliparous female, do mammography annually. If a female is average risk female, in an average risk female, we have to start the screening, and for screening of average risk female, we start mammography. At what age mammography should be started? It should be started at 45 years of age. Initially it was 40, nowadays it is 45 years of age. So for average risk female, mammography should be started at 45 years of age and it should be performed annually. But this female is high risk female, and in high risk females, investigation of choice for screening of breast cancer, that is MRI. And in high risk females, at what age we should start MRI? MRI should be started at 30 years of age. 30 years of age. So obviously we are not going to do the mammography. Her age is 37, and second, she is a high risk female. Genetic counseling and BRCA testing, yes. Any female patient who is having positive family history in which two family members are having breast cancer or ovarian cancer. So this is an indication for obviously genetic testing, genetic counseling. And you know that in BRCA1 as well as in BRCA2 mutation, there is increased risk of carcinoma breast and carcinoma ovary. Imagine patient is having BRCA1 mutation. So how much is the lifetime risk of development of carcinoma breast? The lifetime risk of development of carcinoma breast, and that is 60 to 80%. And how much is the risk of carcinoma ovary? The carcinoma ovary risk is 30 to 40%. Clear? Fourth option is immediate prophylactic mastectomy. No. First we have to confirm whether she is having BRCA mutation or not. If the patient is having BRCA mutation, after that only prophylactic bilateral mastectomy and prophylactic bilateral salpingo oophorectomy is recommended. So immediately we are also not going for prophylactic mastectomy. So what is the correct answer? The correct answer for this question is genetic counseling and BRCA testing. Okay, see the indications for consideration of genetic testing as given in Subiston 21st edition. First, breast cancer diagnosed before 50 years of age, or the female patient is having bilateral breast cancer, or patient is having breast and ovarian cancer. In the same patient both cancer are there, or there is breast cancer in males or in men. The other factors which are included for genetic testing, This was there in our question. What? That family history of 2 or more individuals with breast and ovarian cancer. This was in our question. Mother was having breast cancer, sister was having ovarian cancer. So 2 or more family members with breast and ovarian cancer, or close male relative with breast cancer, or close relative with early onset, means breast cancer in patient whose age is less than 50 years. So there is breast or ovarian cancer, or the patient is having BRCA1 or BRCA2 mutation in the family. Clear? So if you see the question again, in this question, 2 or more family members are having breast or ovarian cancer. So 2 family members are having. In this case, we will go for genetic counseling and BRCA testing. And if BRCA mutation is positive, in such patients, we recommend prophylactic bilateral mastectomy. And what else we are going to recommend? Yes, prophylactic bilateral salpingo-oophorectomy. Prophylactic bilateral salpingo-oophorectomy. Clear? So correct answer for this question is C. Question number 2. Patient was taking tamoxifen for the last 5 years after breast cancer surgery. When will she stop the tamoxifen if she wants to conceive? So why she has to stop tamoxifen? Because tamoxifen is having teratogenic effect. It is having teratogenic effect. You know that the drug of choice for hormone therapy in premenopausal females is tamoxifen. Tamoxifen is the drug of choice for hormone therapy in premenopausal females. How much is the dose? It is 10 mg BD, and minimum duration it's given for 5 years. According to some latest trials, it is said that it should be given for 10 years. So 10 mg BD for 5 years minimum duration. But drug of choice for hormone therapy in postmenopausal females, it is aromatase inhibitors. Aromatase inhibitors, this is for postmenopausal females. Simple. Problem. This tamoxifen is having teratogenic effect. So if female wants to conceive, we have to stop it. And what is the washout period before pregnancy? For tamoxifen, the washout period is 2 months. Washout period of tamoxifen, that's 2 months. It means for complete washout of the drug, it takes 2 months. So that's why at least tamoxifen should be stopped 2 months before the pregnancy. Clear? So see the options. 1 month before, no. Just stop and conceive, no. Must continue even at pregnancy, no, because of teratogenic effect. So correct answer for this question is 3 months before. Minimum 2 months before pregnancy. So here the correct answer is 3 months before. Question number 3. This is an easy question. All of the following releases neurosecretory granules except. You know that these neurosecretory granules are secreted by neuroendocrine tumors. These are secreted by neuroendocrine tumors. So out of the given options, you have to rule out that which one is not included in neuroendocrine tumors. Paraganglioma, it is included. Medullary carcinoma thyroid included. Pituitary neuroendocrine tumors included. So A, C, D, all these are going to secrete neurosecretory granules. Adrenocortical tumor, it's not a neuroendocrine tumor. It is not secreting neurosecretory granules. So correct answer for this question is B. Question number 4. If you read the language of question or if you see the image, you can easily make the diagnosis. That what is the diagnosis? See, 40 years old male presented to OPD with right flank pain. Where is the pain? In the right flank. It means the problem is related to kidney. Right? CT scan was done whose image is given below. Which of the following statement is incorrect about this condition? So see the image. If you see the image, in the right kidney, you can see there are multiple cysts. Presence of multiple cysts. So these multiple cysts are what? hydatid cyst. See the options also. Albendazole is mentioned, dog tapeworm is mentioned, leakage leads to anaphylaxis. So the things are related to what? Hydatid cyst. And you know what is the organism? It is dog tapeworm. What is the name of this dog tapeworm? This is Echinococcus granulosus. So it is caused by dog tapeworm, that is Echinococcus granulosus. You already know that definitive host is dog, intermediate host is sheep, and man is accidental dead end intermediate host. Accidental dead end intermediate host without human to human transmission. Okay, if a patient is having hydatid cyst, how you are going to make the diagnosis? Serology. So investigation of choice for diagnosis is that is hydatid serology. This is hydatid serology. Whenever the diagnosis is confirmed, obviously we have to start albendazole, and that is drug of choice for perioperative chemoprophylaxis. Drug of choice for perioperative chemoprophylaxis is albendazole, alternative is mebendazole. Clear? We have to be careful, because whenever we are handling the cyst, and if there is rupture of the cyst or content is going to spill, or leakage of the content can cause anaphylaxis, right? So see the options. First option is FNAC or biopsy is required before surgery. No, FNAC and biopsy is not required before surgery. Albendazole is given preoperatively. Yes, is the drug of choice for preoperative chemoprophylaxis caused by dog tapeworm. Yes, it is Echinococcus granulosus, and leakage of cyst can cause anaphylaxis. Yes, that's correct. So which option is incorrect? This is option A. See the question number 5. A similar question was asked in NEET PG also. On the basis of given image, what is the diagnosis? So if you see this image, what you can see, there is a growth arising from fundus. And what kind of growth? If you see it carefully, it is infiltrative growth. So chances are that the patient was having polyp which became malignant. Clear? So it's a malignant polyp or carcinoma gallbladder. Okay, so see the options. It's the gallbladder polyp, it can be, but it's malignant. Carcinoma gallbladder, cholesterolosis, gallbladder stone. So we have to choose between A and B. Most of the gallbladder polyps are benign. So out of these two, which one you have to choose? It is carcinoma gallbladder. Why? Because of infiltrative growth. What kind of growth is there? It is infiltrative. So correct answer for this question is carcinoma gallbladder or malignant polyp. So correct answer will be option B. Some students were telling that similar image was there. So on the basis of given image, what's the diagnosis? So straight away you can see what? That under reddish background, there is deposition of cholesterol esters, which is giving what? This yellow color, and it is looking like what? Strawberry. So what is the name of this condition? Strawberry gallbladder, and the strawberry gallbladder is also known as cholesterolosis. So what is the name? This is cholesterolosis. And what is the cause of cholesterolosis? It is caused by, can you see, deposition of cholesterol, what? Ester. It is caused by deposition of, can you see here, cholesterol ester and triglyceride in epithelial macrophages of gallbladder. Simple. Now everything is related to the cholesterol in strawberry gallbladder. Means it is associated with cholesterol gallstone. It is associated with cholesterol polyp. It is associated with hypercholesterolemia. What are the associations? You have to remember, everything is related to cholesterol. So it is related to hypercholesterolemia. It is related to cholesterol gallstone, and it is associated with cholesterol polyp. This condition is benign and it is acquired. It is benign and it is acquired. So obviously, what is the correct answer for this question? The correct answer for this question is C, strawberry gallbladder or cholesterolosis. Read the question number 7. A 46 years old alcoholic and smoker. See the factors, two risk factors. Alcoholic and smoker male presented with 2 months history of waxing and waning of jaundice. This is a characteristic feature. You must be knowing that in which particular case or in which particular malignancy waxing and waning of jaundice is there. Yes, ampullary carcinoma, which is the part of periampullary carcinoma. CT shows dilatation of CBD and pancreatic duct, right? So see the image first. This is the liver, this is the gallbladder, this is the bile duct, this is the duodenum. Where is the malignancy? Generally, malignancy arises from ampulla, that is ampullary carcinoma. And whenever malignancy arises within 2 centimeter of ampulla, that is periampullary carcinoma. Whenever patient is having ampullary carcinoma, obviously the proximal part of bile duct will be distended, as well as there will be pancreatic duct dilatation. Simple. What is the problem? Every 2 to 3 months, this part, the most medial part of growth, it is sloughed because its vascularity is gone. And if this part is sloughed, its vascularity is gone, what is the problem? There is partial relief in the jaundice. So this is known as waxing and waning of jaundice. Whenever this sloughing will occur, what will happen? There is bleeding, and because of this bleeding, there is melena. So every 2 to 3 months, patient is going to tell you that, sir, I'm having waxing and waning of jaundice and I'm having melena. So there is waxing and waning of jaundice and patient is having melena every 2 to 3 months. This is classical feature of ampullary carcinoma, not seen in all patients of ampullary carcinoma, seen only in 1/3 of patients. How many patients? Only in 1/3 of the patients. So since ampullary carcinoma is not mentioned, in periampullary carcinoma we include it. So the correct answer for this question is B. And similar question was asked in AIIMS previously also. So it was a direct repeat question, and here you can see smoking is a risk factor for carcinoma pancreas. Alcohol increases the risk of chronic pancreatitis, which is further a risk factor or an association for carcinoma pancreas. Clear? So waxing and waning of jaundice, it is seen in ampullary carcinoma. Correct answer for this question is B. See another question related to carcinoma pancreas. On the basis of given image, which cancer is operated here? So see, what is done? If you see this anastomosis, this is pancreaticojejunostomy. Pancreas is sutured to the jejunum. If you see this anastomosis, this is hepaticojejunostomy or choledochojejunostomy, and here stomach is sutured to jejunum. So this is gastrojejunostomy. So here pancreaticojejunostomy, hepatico or choledochojejunostomy, and gastrojejunostomy. So this is Whipple's procedure, which is also known as, this is Whipple's procedure, which is also known as pancreaticodiodinectomy. So here pancreaticodiodinectomy has been done, and after that this is the sequence of anastomosis, and it is performed for carcinoma head of pancreas. So what is the correct answer? It is carcinoma head of pancreas. Okay, see what's the specimen removed and what's the sequence of anastomosis in Whipple's procedure. So in this diagram you can see we are going to remove the distal part of stomach. So distal gastrectomy is done. Whole C loop of duodenum has been removed. Some part of proximal jejunum is removed. Okay, then we remove gallbladder, some part of bile duct, head and neck of pancreas. Clear? So this is the specimen which is removed. This is the resected specimen. After this specimen, what is the sequence of anastomosis? The most important anastomosis is PJ, that is pancreaticojejunostomy. Second anastomosis is HJ or choledochojejunostomy, and the third anastomosis is GJ, that is gastrojejunostomy. Clear? So if you see the question, the correct answer for this question is B. It is Whipple's procedure performed for carcinoma head of pancreas. Question number 9. Similar questions were asked many times in INI-CET, AIIMS, in NEET PG. A 30 years old patient with history of progressive difficulty in swallowing for both solids and liquids for 8 months. See, whenever the question is like this, that there was dysphagia to liquids more than solids or dysphagia to both solids and liquids, you should think about what? Achalasia cardia. Because in achalasia cardia, dysphagia is more to liquids as compared to solids. Which investigation is not commonly used in the condition whose image is given below? So what is this image? This is barium swallow, and in this barium swallow, what you can see, this is bird beak appearance, which is also known as pencil tip appearance, also known as rat tail appearance. So this is bird beak appearance. On barium swallow, this bird beak appearance is seen in achalasia cardia. So what's the diagnosis here? The patient is having achalasia cardia on the basis of history as well as this barium swallow. In achalasia cardia, what is the investigation of choice? It is high resolution manometry. So for motility disorders, investigation of choice is manometry. Clear? We perform barium swallow. In motility disorders, these kind of characteristic findings are seen or signs are seen. You know that achalasia cardia is a risk factor for carcinoma esophagus. Why? Because there is continuous and chronic inflammation. So because of this, there is increased risk of squamous cell carcinoma. If we suspect malignancy in achalasia cardia, obviously we go for endoscopy, and if malignancy is there, we go for biopsy. Right? See the options. 24 hours pH monitoring. You know that 24 hours pH monitoring, it is the investigation of choice for diagnosis of GERD. Gastroesophageal reflux disease, it is not related to the diagnosis of achalasia cardia. So this is not commonly used for the diagnosis of achalasia cardia. Manometry, we discussed, this is an investigation of choice. Upper GI endoscopy, whenever we suspect malignancy, that is squamous cell carcinoma, and barium swallow image is already given, where you find bird beak, pencil tip or rat tail appearance. So these three are done, but 24 hours pH monitoring is not done. So correct answer for this question is A. Question number 10 is related to question number 9. Which is the investigation of choice to diagnose the above mentioned disease? That was achalasia cardia. So we discussed it is manometry. So this is the investigation of choice for diagnosis. Correct answer is A. Now the question number 11. Nutritional complications are more with which fistula? This is the repeat question. Let me tell you, if a patient is having proximal small intestinal fistula, so in patients who are having proximal small intestinal fistula, what happens? There is higher output, and if there is higher output, there is higher fluid and electrolyte imbalance or losses, increased loss of digestive capacity. So there is higher output. Obviously, there is increased fluid and electrolyte losses, and there is increased loss of digestive capacity. Okay, let's discuss it with one example. Imagine patient is having duodenal fistula and ileal fistula. If there is duodenal fistula, whatever the content patient has eaten, the food stuff, the digestive enzymes, the bile, most of that will start coming out. Clear? Suppose fistula is in the ileum, so most of the nutrients are already absorbed in the jejunum. Digestion has been done, absorption has been done already. It means if we are going to compare duodenal fistula from ileal, obviously which one is having more complications? Duodenal, because it's a type of proximal fistula. So if you see the options, what is the correct answer? Obviously it is duodenal fistula. So proximal fistulas are having increased risk of nutritional complications as compared to distal fistula. Correct answer for this question is C. See the literature also, what's written in Subhiston. Enterocutaneous fistulas are classified according to their location and volume of daily output. right? And obviously these factors are going to dictate the treatment, morbidity and mortality. If we are going to discuss proximal fistula, can you see here? There is higher output and obviously there will be greater fluid and electrolyte loss. Because of that, there is loss of digestive capacity. If we see the distal fistula, obviously there will be lower output, making them easier to manage, and these are going to close spontaneously in comparison to proximal fistula. Okay, so if you see the question again, nutritional complications are more with proximal or duodenal small intestinal fistula. Question number 12. Most common ectopic tissue found in Meckel's diverticulum. Okay, Meckel's diverticulum is very important topic. You can see how it looks like. So this is Meckel's diverticulum. You know, it's a true diverticulum, single, congenital, contains all the three layers, and it's the most common congenital abnormality of midgut. What is the cause? It is because of persistent vitellointestinal duct or omphalomesenteric duct. What is the problem? That in Meckel's diverticulum, generally there is ectopic gastric mucosa, and because of this ectopic gastric mucosa, there is ileal ulcer, and because of this ulcer, most common presentation is bleeding. So the most common mucosa is gastric, followed by pancreatic, followed by colonic, right? So it is gastric, followed by pancreatic, followed by colonic. You know that Meckel's diverticulum is characterized by rule of 2. Rule of 2. And what is this rule of 2? It is seen in 2% of population. 2 inches in length, located 2 feet proximal to IC junction, and symptomatic patients are less than 2 years of age. So if you see the options, most common ectopic tissue in Meckel's diverticulum, it is gastric, followed by pancreatic, followed by colonic, right? So see the options. There should be 1, 2, 3, or at least the option should contain 1 and 3. So which one is correct? It is option 1, A. So option A, which include 1 and 3. So you have to remember mnemonic GPC. Gastric, pancreatic, colonic. This is the ectopic gastric mucosa. And for the diagnosis of Meckel's diverticulum, we go for technetium 99 per technete scan. So this is technetium 99 per technete scan. This is the investigation of choice. So correct answer for this question is A. Question number 13. In each and every paper, you are going to get one question related to what? Inflammatory bowel disease, related to what? Tension pneumothorax. So see, inflammatory bowel disease. All of the following statements are true about inflammatory bowel disease except, so first option, Crohn's disease has skip lesions. Yes. Childhood IBD is genetic. Childhood IBD, inflammatory bowel disease. Yes. If you see in Crohn's disease, card 15, or there is NOD2 mutation, and generally it is located on chromosome number 16q. This question was asked in exam also. So there is card 15 NOD2 mutation located on chromosome number 16q. So this is also correct. Crohn's disease is mucosal. Ulcerative colitis is transmural. No, it's the vice versa. You know, Crohn's disease, this is transmural. Transmural means it is involving all the 3 layers: mucosa, submucosa, muscularis propria, and because of involvement of muscularis propria, you know, there is increased risk of strictures in Crohn's disease. So it is transmural, it is having skip lesions, and we don't have curative treatment for Crohn's. There is no curative treatment. If you see ulcerative colitis, in ulcerative colitis, there is continuous uninterrupted inflammation. So what kind of? There is continuous uninterrupted inflammation. Clear? And it is involving only mucosa and submucosa. there is only involvement of mucosa and submucosa, and since continuous lesion is there, most commonly involved segment is rectum. It moves cranially upwards and involve colon. So here we can perform total proctocolectomy, means surgery is curative. Surgery is curative because there is involvement of rectum. Then it moves cranially upwards, can involve colon. We can perform total proctocolectomy. So surgery is curative. Now see the option C. Crohn's disease is mucosal. No, it is transmural. And ulcerative colitis, this is not transmural. It is involving only mucosa and submucosa. So this is incorrect. Crohn's is fully curable. It is incorrect. So what? Only 1 and 2 are correct. So what is the correct answer? Correct answer for this question is B. From the last 2 to 3 years, continuously one question is being asked about rectal prolapse. See the question number 14. Rectal prolapse image of 45 years old female is given below. Which of the following is not the perineal approach for rectal prolapse? So you know, for rectal prolapse we have two approaches. One is abdominal and the second is perineal. How to remember? Abdominal, the mnemonic is VAR, and for perineal the mnemonic is PAD. Okay, VAR, W means Wells, A means abdominal, R means Ripstein. So Wells, abdominal, Ripstein. So Wells and Ripstein are abdominal. PAD, P means perineal, A means Altmier's, and Delorme. These are perineal. And you know, the patients who cannot tolerate surgery, in those cases we can go for Thiersch anal wiring also. Thiersch anal wiring. Clear? So this is also a type of perineal approach for the rectal prolapse. Now see the question. So Ripstein, this is abdominal. Altmier's, Delorme, Thiersch, these are perineal. Clear? So what is the correct answer? The correct answer for the question 14 is A. Ripstein. It's not perineal, it's abdominal approach. There was one image-based question related to Thiersch procedure or Thiersch anal wiring in NEET PG. So what we do, you can see that we are going to apply band, silastic tape or suture around the anal canal. So this is the anal tightening so that there is no prolapse. So this is Thiersch, here you can see Thiersch anal wiring. Clear? Generally, it is done for the patients who cannot tolerate the long duration surgery. It's a type of perineal approach for rectal prolapse. See the question number 15. Similar questions were asked in AIIMS many times before. So see, patient developed loss of sensations in the root of penis after laparoscopic hernia surgery. Which of the following nerves would have been damaged? So first see, what's the nerve supply of root of penis? There is ilioinguinal nerve which is distributed to skin of upper and medial part of thigh. In males and females, the name of nerve is different. In males, it is known as anterior scrotal nerve. This anterior scrotal nerve supplies skin over the root of penis and upper part of scrotum. It's a branch of ilioinguinal nerve, and in females it's known as anterior labial nerve, which is going to supply the skin covering mons pubis and labia majora. Simple. So see the question again. So here there is loss of sensation in the area around root of penis. So obviously what is the injured nerve? That is ilioinguinal nerve. There are two other questions which are asked commonly in the exams, that what is the most commonly injured nerve in laparoscopic hernia repair, and that is lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh followed by genitofemoral nerve. And if you see, most commonly injured nerve in open hernia repair, that is ilioinguinal, followed by iliohypogastric, followed by genital branch of genitofemoral nerve. Genital branch of genitofemoral nerve. So how to remember? Mnemonic is GHI. I means ilioinguinal, H means hypogastric, so this is iliohypogastric, and G, that is genital branch of genitofemoral nerve. So these questions are also asked, and if the question is asked like there is loss of sensation of root of penis after laparoscopic hernia repair, so obviously it is ilioinguinal nerve. Correct answer for this question is B. See the question number 16. Again a repeat question, indirect repeat. Which of the following statement is true about clear cell carcinoma? You know that the most common variant of RCC is the clear cell. Cell is not clear, cell contains glycogen and fat. This glycogen and fat is washed away by acetone and alcohol during staining and fixation. That's why cell appears clear. So cell contains glycogen and fat or lipid. You know, in more than 96% cases, clear cell is sporadic. It is sporadic, and in less than 4% cases, it is familial. It is because of VHL gene mutation or deletion, and you know this gene is located on chromosome number 3p, that is short arm of chromosome number 3, and clear cell variant arises from proximal convoluted tubule. It arises from proximal convoluted tubule. So see the options. It contains glycogen and lipid. That's correct. Mostly sporadic. Yes, more than 96% cases are sporadic. Due to deletion of chromosome number 3q. No, it is 3p. So this is incorrect. And it arises from DCT. No, it arises from PCT. So 1 and 2 are correct. So what is the correct answer for this question? Correct answer is option A. Question number 17. It is related to pharmacology. So see, after taking 5 alpha reductase inhibitors, PSA increases, decreases, testosterone increases, intracellular dihydrotestosterone decreases. So you know that testosterone, it is not an active substance, and this testosterone is converted into 5-dihydrotestosterone. 5-dihydrotestosterone by which enzyme? 5-alpha reductase. Clear? And that's why we use here what? 5-alpha reductase inhibitors. If you are going to use 5-alpha reductase inhibitors, obviously testosterone will not be converted into 5-dihydrotestosterone. So 5-dihydrotestosterone level will start decreasing, testosterone level will increase, and 5-alpha reductase inhibitors, it has been seen that after its use, there is increase in PSA. So what happens? PSA increases after 5-alpha reductase inhibitors use, testosterone increases, but dihydrotestosterone levels decreases. So what are the options? PSA increases, correct. Decreases, this is wrong. Testosterone increases, yes. Intracellular dihydrotestosterone decreases, that's correct. So 1, 3 and 4, these are correct. So correct answer for this question is D. What is the size of prostate in young adult male? It is 3 cm into 3 cm into 5 cm. This is the normal size of prostate. And what's the volume? Volume is 20 to 25 ml. This is the volume. Obviously, weight is 20 to 25 grams. So normally, the volume is 20 to 25 ml. Weight is 20 to 25 grams, and the size is 3 into 3 into 5 centimeter. So what is the correct answer for this question? The correct answer for this question is A. See the question number 19. A 30 years male following pelvic trauma and hip fracture was brought to the casualty. So here there is pelvic trauma and this patient was having hip fracture. There was no blood at the tip of meatus. Important finding that there is no blood at the tip of meatus. Urine output was minimal. So there was minimal urine output following catheterization. It means catheterization has been done. There was no blood at meatus. It means urethral injury has been ruled out, because in urethral injury there is blood at the meatus. Radiological image is given below. How will you manage this patient? Okay, so there is history of pelvic trauma, and what you can see in this image, have a look. So in this image you can see here that there is one catheter which is inserted into the bladder and dye has been injected. So obviously this is cystogram, and what kind of cystogram? This is retrograde cystogram. This is retrograde cystogram. Clear? So this black arrow suggests that bladder is filled with contrast. Okay, and if you see this white arrow here, you can see that there is extravasation of contrast. So if there is extravasation of contrast from the bladder, what kind of bladder rupture is this? Intraperitoneal or extraperitoneal bladder rupture. So when there is intraperitoneal bladder rupture, obviously there is extravasation of urine. So here you can see that there is extravasation of contrast. So this is intraperitoneal bladder rupture. Intraperitoneal bladder rupture. What are the signs and symptoms? Yes, in bladder rupture there is suprapubic pain, there is difficulty in passing urine, and there is hematuria. Since there is extravasation of urine in intraperitoneal bladder rupture, so apart from suprapubic pain plus difficulty in passing urine plus hematuria. So apart from this, because of extravasation of urine, what? The patient is having peritonitis. Patient is having peritonitis, and since there was extravasation of urine, and that's why when Foley's catheterization was done, there was minimal urine coming out. Simple. So what is the diagnosis? This patient is having intraperitoneal bladder rupture. Easily you can see on this cystogram that there is extravasation of contrast into the peritoneal cavity. And how you are going to manage this patient who is having intraperitoneal bladder rupture? Because there is peritonitis, urine is going to contaminate the peritoneal cavity. So obviously we have to go for exploratory laparotomy. We perform peritoneal lavage and we repair the bladder defect. So see the question again. So if you see the question again, history of pelvic trauma, hip fracture, no blood at meatus, and minimal urine output following catheterization, cystogram showing extravasation of urine, means extravasation of contrast into the peritoneal cavity. So how will you manage this patient? SPC, suprapubic catheterization? No. SPC is done in patients who are having urethral injury, and here you can see no blood at meatus. Since there is no blood at meatus, it is going to rule out the urethral injury. So no SPC. Per urethral catheterization, it has been done already, and generally per urethral catheterization it is sufficient for which patients? The patients who are having what? Extraperitoneal bladder rupture. The patients who are having extraperitoneal bladder rupture, for that catheterization is sufficient, because within 7 to 10 days that rupture heals spontaneously. Pelvic packing and bilateral nephrostomy, that's not required here. So correct answer for this question is laparotomy. We perform laparotomy, we perform peritoneal lavage, and we repair the bladder defect. So correct answer for this question is laparotomy. Why? Because what is the diagnosis? This is intraperitoneal bladder rupture. Question number 20. A deep ulcer in the heel of patient whose image is given below is associated with. So you tell me, in which patients you are going to find the ulcer at bony prominences? So these kind of ulcers are known as pressure ulcers or trophic ulcers. These are pressure ulcers or trophic ulcers. What are the causes? It is because of prolonged pressure, or there is decreased sensation. Clear? Because of neurological causes. So these kind of ulcers are located at bony prominences. Now see the options. First option is positive Trendelenburg test. And you know that there is a Brody Trendelenburg test. That Brody Trendelenburg test, it is performed for which condition? It is performed for varicose vein. And in varicose veins, what kind of ulcer is seen? That is varicose ulcer. And you tell me, what is the location of varicose ulcer? It is located just above medial malleolus, especially in which particular area? Gator's region. And this region is located between medial malleolus and the calf muscle. So, it is not varicose ulcer. Decreased pulsation of dorsalis pedis artery. So, in which kind of ulcers there is decreased pulsation of artery or there is decreased vascular supply? Yes, ischemic or arterial ulcer. And these ischemic or arterial ulcers are punched out ulcers. And what is the location of arterial ulcer or ischemic ulcer? Lateral surface of ankle or digits. Clear? So, obviously this is also ruled out. D option, pain on passive movement of calf muscle. So, if a patient is having deep venous thrombosis, any kind of passive movement can lead to pain in the calf region. Clear? So, this is suggestive of DVT, and sometimes patients of DVT are also having ulcer. Those are venous ulcers. Venous ulcers. So, this is not the venous ulcer. This is also ruled out. Decreased sensation of foot. So, obviously, because of decreased sensation of foot, especially in the neurological causes at bony prominences, there are ulcers which are known as pressure ulcers, pressure sores, trophic ulcers. So, correct answer is C, that is decreased sensation of foot. So, this is a case of trophic ulcer. It is because of decreased sensation of foot, and generally it is located at bony prominences. Ulcers are very important. See, tell me, what is this ulcer? So, if you see the location, it is located between Gator's region, means between medial malleolus and the calf muscle. This is Gator's region. What kind of edges are seen in venous ulcers? These are having sloping edges. Sloping edges. And in the surrounding, you can see hyperpigmentation because of varicose vein. If you see this ulcer, this is punched out. If you see the condition of skin, it is thin, shiny, and here you can see what? There are brittle nails, loss of hair. So, all these are indirect evidences of decreased vascularity. So, this is arterial ulcer. And what kind of ulcer? These are punched out. These ulcers are punched out. Apart from that, there are skin changes like thin, shiny skin, loss of hair, and there are brittle nails. So, what is the most common site of trophic ulcer? It is ischium, followed by greater trochanter, followed by sacrum, followed by heel, followed by malleolus, followed by occiput. So, how to remember? Mnemonic is Indira Gandhi Stadium, inaugurated by Home Minister's Office. So, it is easy to remember now. The most common site is ischium, followed by greater trochanter, followed by S, sacrum, followed by H, heel, followed by malleolus, followed by occiput. Simple. So, here you can see there is presence of ulcer at a bony prominences, that is the heel. So, this is a patient who is having trophic ulcer, and one of the cause of trophic ulcer is neurological causes leading to decreased sensation. So, correct answer for this question is C. Question number 21. Which of the following is the true statement for full thickness and split thickness skin graft? So, first you should understand that what is split thickness skin graft and what is full thickness skin graft. STSG, that is split thickness. Here we are going to include epidermis plus part of dermis. Epidermis plus part of dermis. Simple. And what is full thickness skin graft? This is epidermis plus full thickness of dermis. You know that split thickness skin graft is also known as Thiersch, is the Thiersch graft, and this is Wolff's graft. Wolff's, right? Now, what is primary contraction and what is secondary contraction? Primary contraction is because of presence of elastin fibers. It's the recoil of primary contraction. It is because of recoil of elastin fibers which are located in dermis. Clear? So, any graft which is having more thickness of dermis, obviously there is increased content of elastic fibers and obviously there will be more primary contraction. So, simple, primary contraction will be more in any graft where the content of dermis is more. So, primary contraction is more in full thickness skin graft. So, come on, one more time. Primary contraction is because of passive recoil of elastin fibers which are located in dermis. So, if thickness of dermis is going to increase, obviously there is increased recoil that is responsible for primary contraction. And what is secondary contraction? Secondary contraction is shrinkage of skin graft. It is shrinkage of skin graft by myofibroblast. Myofibroblast. Okay, shrinkage by myofibroblast. Let me tell you, dermis is resistant to pull of myofibroblast. So, any graft in which the content of dermis is more, obviously that will be relatively resistant to secondary contraction. So, secondary contraction, full thickness skin graft, it is resistant. Why? Because there is dermis and dermis is resistant to pull of myofibroblast. So, secondary contraction is mainly seen in split thickness skin grafting. Clear? So, how to remember? S, that is secondary contraction, S, that is split thickness skin grafting. So, you have to remember secondary contraction is more in split thickness skin grafting, primary contraction is more in full thickness skin grafting. Simple. Now, look at the options. Primary contraction more with split thickness skin grafting, incorrect. Secondary contraction more with split thickness skin grafting, this is correct. Primary contraction more with full thickness skin grafting, correct. And secondary contraction more with full thickness skin grafting, correct. So, I am repeating again, primary contraction more with full thickness skin grafting, and S for S. So, secondary contraction is more with split thickness skin grafting. So, what is correct? 2 and 3 are correct. So, correct answer for this question is B. B is the correct answer. Question number 22. Which of the following are true regarding frostbite? What is frostbite? It occurs when a part of body freezes. So, when a part of body freezes. In that case, what we have to go for? So, whenever there is a patient of frostbite, we have to go for rewarming, right? We have to start analgesics because there is pain. To prevent infection, we have to clean and dry the area, and in certain cases, we have to give antibiotics to prevent the infection. Sometimes there is a clear demarcation of dead tissues and alive tissues. So, whenever there is clear demarcation of dead tissue, you have to excise. So, generally we can go for amputation, but amputation is done a bit late in severe cases. So, again, how we manage a patient of frostbite? We go for gentle rewarming. Gentle rewarming. We start analgesics, especially NSAIDs, to take care of pain. To prevent infection, we have to clean and dry the area, and sometimes we have to give antibiotics to prevent the infection, and amputation is done a bit late in severe cases. Excision of dead tissues. Simple. Now see the options. Which of the following are true regarding frostbite? So, option number 1, amputation in severe cases. Yes, it's correct. Antibiotics and analgesics are not used. No, these are used. So, this is incorrect. Rewarming, not done. It is done. So, this option is also incorrect. Clean and dry the area. Right? So, this is correct. So, option number 1 and option number 4 are correct. So, correct answer for this question is B. Frostbite is important topic. See how we manage the patients. So, here you can see the warming should be gentle as heat use may actually cause a burn. Second, we have to start the rehydration with warm fluids. To take care of pain, we should give NSAID, especially Brufen. Generally what happens, there is demarcation between dead and viable tissues, and at this stage no surgery should be undertaken. Why? Because sometimes there is deep recovery. So what you have to do, we have to keep the injured area clean and dry, and every effort should be made to prevent the wound infection. So we should give antibiotics also if it's required, and definitive surgery to excise dead tissue can be left for many months. Means amputation can be a bit late and in severe cases. So this is how we manage the patients of frostbite. Question number 23. After fall from height, the patient suffered blunt trauma to chest and abdomen. In which of the following radiographs further investigation is required before inserting the chest tube? Okay, let's have a look of enlarged version of these radiographs. If you see this chest x-ray, here you can see that there is cystic lucency on the left side. Clear? And what is this cystic lucency? Actually, it is a case of diaphragmatic hernia. So what kind of diaphragmatic hernia? This is traumatic diaphragmatic hernia. And if on the x-ray picture looks like traumatic diaphragmatic hernia, you have to confirm the diagnosis. If you are not going to confirm the diagnosis and you are just going to insert the ICD, means chest tube, what happens? You might injure the bowel. And if there is injury to bowel, it can cause fecal fistula. So in cases of diaphragmatic hernia, diagnosis should be confirmed, or this diagnosis should be ruled out before inserting ICD. If you see the second X-ray, here you can see the collapsed lung. And if you are going to compare the diaphragm, yes, here the right side of diaphragm is depressed, there is shift of mediastinum also. So obviously here bronchovascular markings are absent. So this is a case of pneumothorax. What kind of pneumothorax? It's a case of tension pneumothorax. And whenever there is tension pneumothorax, what we have to do immediately, or on the basis of suspicion, because this is a clinical diagnosis, on the basis of suspicion, put a wide bore needle. Where? In children, second intercostal space in midclavicular line. In adults, fifth intercostal space in anterior axillary line. And what is the treatment of choice? ICD insertion or chest tube insertion. So in this case, straight away after wide bore needle insertion, when you get some time, you insert ICD. In this case, you can see what? That there is fracture. Clear? So what is the definition of flail chest? When there is fracture of 2 or more than 2 consecutive ribs at 2 or more than 2 places. This is flail chest. In this case also, if it is required, we can go for ICD insertion. In this case, you can see that there is blunting of CP angle. And what you can see that there is opacification of lower half of left hemithorax. It is seen after trauma. It means there is collection of blood. So what is the diagnosis? This patient is having hemothorax. And in case of hemothorax, obviously what you have to do, you have to insert ICD. ICD insertion is done. So see the question again. We discussed that first option, this is diaphragmatic hernia, traumatic diaphragmatic hernia. Second option was tension pneumothorax. Third option was flail chest. And the fourth option was hemothorax. This is hemothorax. So in which case further investigation is required before insertion of ICD? In option 1, we have to rule out diaphragmatic hernia before inserting the chest tube, otherwise it can cause injury to the bowel, it can lead to fecal fistula. So correct answer for this question is option A. Question number 24. Which of the following statements are correct about psoas abscess? So see, what's the one of the most common cause of psoas abscess? It is pot spine. Pot spine. And what is the location of psoas abscess? Obviously, it's retroperitoneal. Now, what is the problem? The pus tracks along iliopsoas. So if pus tracks along iliopsoas, you can find a fluctuant swelling in the thigh region, right? Second, whenever we are performing extension at the hip joint or there is fixed flexion at hip, it can lead to pain. Nowadays, especially in the immunocompromised patients, what happens? There is hematogenous spread, and this is known as primary psoas sepsis. Okay, so see the options one by one. Option number 1, fluctuant swelling can be elicited in the thigh region. Yes, because the psoas sepsis tracks along iliopsoas. It tracks along iliopsoas muscle. So this is correct. Pot spine can present psoas sepsis. Yes, this is one of the common causes of psoas sepsis. Pain occurs during extension at the hip joint. This is correct. Caused by hematogenous spread of tuberculosis in immunocompromised patient. Yes, this is known as primary psoas sepsis. So this is also correct. So all 4 options are correct. 1, 2, 3, 4. So correct answer for this question is option D. Let's have a look of literature also. Psoas sepsis is a relatively uncommon diagnosis, and it was mainly caused by tuberculosis of spine, and that is Pott's spine or Pott's disease, right? In recent years, the primary psoas sepsis occurs because of hematogenous spread from an occult source, and especially it is seen in the patients who are immunocompromised, elderly patients, and the patients who are using IV drugs. So in immunocompromised, in elderly, in IV drug abusers from occult source, there can be hematogenous spread. This is known as primary psoas sepsis. If you see the presentation, generally the location is retroperitoneal, so there is back pain, there is pus collection, so there is fever, there is lassitude. Since it tracks along iliopsoas, so swelling may point to the groin. Sometimes you can feel the swelling in the thigh. And pain may be elicited by passive extension of hip or sometimes fixed flexion of hip evident on inspection. So these are important points which are frequently asked in relation to psoas sepsis. Question number 25. Which of the following is not seen in pleomorphic adenoma? Right? This question is related to pathology. So see, what are the components of pleomorphic adenoma? What are the components of pleomorphic adenoma? So there is epithelial component as well as stromal component. Since there is both epithelial and stromal component, what is the other name? It is also known as mixed tumor. This is also known as mixed tumor because it is having epithelial as well as stromal component. There is presence of myoepithelial cells. What kind of stromal component is there? It can be myxoid, it can be chondroid, myxoid, chondroid or myxochondroid. Myxochondroid. Simple. Another important point, you know that there is presence of keratin pearls, and these keratin pearls are characteristic features of squamous epithelium. Clear? So when patient is having squamous cell carcinoma, obviously there is keratin pearls. Now what happens in pleomorphic adenoma? There is squamous metaplasia. So if there is squamous metaplasia, because of this squamous metaplasia, you can find what? Keratin pearls. You can find keratin pearls, okay? And you know that in patients who are having pleomorphic adenoma, there is presence of fibrous capsule, and fibrous capsule involvement can be seen in pleomorphic adenoma. Pleomorphic adenoma, it's a benign tumor. It's a benign tumor. Involvement of nerve, it is seen in malignant tumor. And this perineural invasion is the characteristic property of which salivary gland tumor? That is adenoid cystic carcinoma. It is seen in malignant tumor, especially which one? It is a feature of adenoid cystic carcinoma. Simple. So see the question once again. Which of the following is not seen in pleomorphic adenoma? Keratin pearls, it can be seen if there is squamous metaplasia. Chondromyxoid stroma, it's there. Capsule involvement, there can be capsule involvement. Perineural invasion is not seen because a feature of malignant tumor, especially adenoid cystic carcinoma. So correct answer for this question is D. Question number 26. lethal strains or high risk strains of HPV is associated with all of the following except. So first see the strains. In HPV, there is strain number 6, 11 and 16 and 18. Clear? Because of strain 6 and 11, there is anogenital warts, and it also leads to respiratory papillomatosis. Simple. The strain number 16 and 18, these are high risk strains. And by 6 and 11, there is increased risk of anogenital warts. By 16 and 18, there is increased risk of anogenital cancers. Simultaneously, oropharyngeal cancers also. So, anogenital cancers as well as oropharyngeal cancers, and in these anogenital cancer, what is included? Yes, carcinoma cervix and carcinoma anal canal. It's carcinoma cervix and carcinoma anal canal. Simple. So see the question. Lethal strains of HPV is associated with all of the following except it is associated with carcinoma cervix, oropharyngeal carcinoma, carcinoma anal canal, but respiratory papillomatosis, it is associated with low risk strains like 6 and 11. So correct answer for this question is C. Question number 27. Similar questions were asked many times in the exams. A 34 years old female after road traffic accident was brought to the AIMS emergency with GCS 3. And obviously if the GCS is less than equal 8, so she was intubated. Sent for NCCT and NCCT was normal. Can you believe this? GCS is 3. Means it is the post-traumatic vegetative state and NCCT appears normal. So tell me what is the most common cause of post-traumatic vegetative state in which NCCT appears normal? Obviously, this is a case of diffuse axonal injuries. So what happens? Diffuse axonal injuries, it means there is widespread axonal damage caused by shearing forces. And this is the most common cause of post-traumatic vegetative state where NCCT is normal. Tell me what is the investigation of choice? Investigation of choice for diagnosis, that is MRI. Right? See the options. Before looking at the options, you should see that on NCCT how subarachnoid hemorrhage looks like, SDH and EDH looks like. If you see EDH, extradural or epidural hematoma, it is looking like biconvex or lenticular shaped hyperdense lesion. If you see subdural hematoma, this is concavo-convex hyperdense lesion. And in cases of subarachnoid hemorrhage, here you can see blood filling the subarachnoid cistern and extending into the sylvian fissures, or there can be enlarged temporal horns, or there can be traces of intraventricular bleed. So you can make the diagnosis of EDH, SDH, subarachnoid hemorrhage on NCCT, but NCCT is typically normal in diffuse axonal injuries. And what is the investigation of choice for diagnosis? MRI. So correct answer for this question is A, that is diffuse axonal injuries. Question number 28. A patient of blunt trauma abdomen with grade 3 splenic laceration was being managed conservatively. It means at the time of presentation patient was stable and that's why patient was being managed conservatively. Now, if a patient is being managed conservatively but during management if patient becomes unstable, there is hemodynamic instability. So if patient becomes unstable or there is development of peritonitis, in such patients we have to take the patient for exploratory laparotomy. Now see the options. On second day, for what region you take the patient for laparotomy? Hemoglobin fall from 12 to 10%? No. If there is significant fall, we can take, but from 12 to 10, this is not an indication. Presence of pneumoperitoneum, yes, because pneumoperitoneum means there is perforation, free air is there. Perforation means the patient is having what? Peritonitis. So if there is pneumoperitoneum or patient is having peritonitis, in that case we have to take the patient. Extraperitoneal rupture of bladder we discussed, it can be managed by catheterization. Gallbladder distension, if patient is NPO, there can be gallbladder distension, so this is not an indication. So out of these four, what is the indication for taking the patient for laparotomy? It is B, presence of pneumoperitoneum. So see how we are going to manage the patients of splenic trauma. If a patient of splenic trauma is brought to emergency, what is the first investigation done? It is fast. Doesn't matter patient is stable or unstable. So first investigation done is fast. If fast is negative in stable patients, we send the patient for observation. If it's positive, confirm the findings by CT. If there is high grade injury like grade 4 and grade 5, we perform laparotomy, exploratory laparotomy, and we go for splenectomy. If it is grade 1, 2 or grade 3, we can go for observation if there is no pseudoaneurysm, no contrast blush, or there is moderate bleed absent. Contrast blush means active bleeding is there. If there is pseudoaneurysm, active bleeding is there, we go for angioembolization. If angioembolization is failed, now can you see here? Hemodynamic instability and peritonitis. In such patients, we take the patient for laparotomy. And for grade 1 to 2, when we go for observation, we go for a repeat scan after 72 hours. Unstable patient, fast, obviously it will be positive, and then we go for exploratory laparotomy, right? So this is how we manage the patients of splenic trauma. Question number 29. Blood from donor in Indian setup is usually screened for all except. So first see, in UK, the blood from donor is screened for hepatitis B, virus, hepatitis C, virus, HIV 1 and 2, and syphilis. In UK, the blood from donor is screened for these. In India, the blood for donor is also screened for malaria. So malaria, it's added in India. Simple. But screening is not done for dengue. Clear? So for malaria it's done, for hepatitis B it's done, for HIV it's done, for dengue it's not done. So correct answer for this question is D. So these were the INI-CET questions of May 2022 exams, and most of the questions were from notes and from the videos of PrepLadder. Remember, practice is the key to master any skill. Mind is like a muscle which grows stronger and more capable with use. So keep practicing, grow your mind stronger. Definitely you will get the success. Best of luck.